Uh, my name is Muhammad Israr. I am working as a professor of oral and maxillofacial surgery in Shifa College of Dentistry. At the same time, I am working as a consultant maxillofacial surgeon in Maruf International Hospital for the last 10 years. I will just give a brief go through how we manage oral cancer here in Pakistan. Next. Next.
दोबारा शेयर
नहीं हो रहा है यार अच्छा just before I start about the oral cancer, just think about what oral cavity means to you people. Majority the people working as a dentist, they know what is oral cavity, but our medical colleagues may not know. So the oral cavity starts from the vermiglian border of the lip to the posterior border of the hard palate. That's the anterior posterior. So which include the tongue, the teeth, the gum, the upper jaw, the lower jaw. The soft palate, the tonsil that comes into the oropharynx, they are not part of the oral cavity. So one of my professors used to tell me, as a surgeon, what you need to know, that as is our anatomy, so is our surgery. If you don't know the anatomy, forget about to become a good surgeon. Now, some of the facts about the oral cavity. In general, the head and neck cancer mainly constitute is the oral cancer. The oral cancer is generally the sixth most common cancer in the world. But if you ask me, in Pakistan, it's almost the second most common cancer in Pakistan. As you see, this is one of the studies I found that in worldwide it's of 4 to 6%, but in Pakistan it's 21%. This is old study in Karachi. Now, 95% of these malignancies are squamous cell carcinoma in the oral cavity. And in those cases, 50% are recurrence cases. And the 5-year survival rate of the oral cancer is, you can see, is less than 50% on average. If you talk about this, mainly for the stage 3 and stage 4 disease. But in stage 4 disease, with the mets into the lungs or liver, it dropped to 4%. The survival rate is less than six months. Now, in the oral cavity, the most common site is tongue. But in Karachi, Hyderabad, the most common site is buccal mucosa, because they use this gudka, naswar, chalia, pan. Due to that, majority of cancers are buccal mucosa. Now, majority of these patients, when they present to us, are in stage 3 or stage 4 disease. Majority, I would say, is stage 4 disease. You will hardly find people in stage 1 and stage 2 disease. The reason is what? Maybe the ignorance or inaccessibility to the healthcare. Now, major cause, people say is tobacco, but just to reassure you that there is no specific cause. They are all predisposing factor. Yes, we can see that the oral cancer is most common in those people who smoke, tobacco or alcohol abuse. But I have seen so many patients, they are not taking any alcohol, they are not smoking, they are not taking a swar, still they have oral cancer. So it means that the specific cause, the etiology, we don't know yet. Now, majority are dying because of the ignorance. As I already said, that people don't know. Unfortunately, neither the people know very well about the oral cancer, and unfortunately, not the medical colleagues, they don't know the sign symptom of the oral cancer to detect it in early stage. And that's why people are dying because of the ignorance. Now, we're not going to talk about the risk factor. As I said, the etiology, we don't know. But yes, everywhere you will see tobacco, tobacco, tobacco. Yes, comparatively in those people who smoke, who chew pan, chalia, gudka, yes, they have the cancer is more spread among them. Now, one of the things which is coming more now as a dentist, that any sharp tooth, please, I have seen with my own eyes, sharp tooth is causing oral cancer. Chronic trauma. Why? Because it's a chronic trauma. Now, one of the other things which is coming very fast is HPV. You know the HPV? So this is it's proven in the cervical cancer. Now it's proven in the oropharyngeal cancer, but their role in specific oral cancer is very limited, but their role is very, very important in hypopharyngeal cancer, just for clarification. Now, one other thing which as a dentist we ignore is the candidal infection. You can see the candidal infection very common, but chronic candidiosis, especially at the commissure of the mouth, please don't ignore it and treat it aggressively. Now, presentation, how it presents, usually the most common thing is non-healing ulcer in the form of ulcer or mass or red or white lesion, as you already know, but this is mainly for my medical colleagues, that any red or white patch, we should not ignore it. And if the patient is coming with the low teeth or red patches, or lump and bumps in the mouth and neck, please refer to Maxillofacial surgery or ENT colleagues or to the appropriate person. But please don't ignore it and don't treat it yourself. Now, once the patient comes to you after taking the history clinical examination, one of the most important things which we ignore is photography. As I said, that in my life, I have seen one case a few months ago in Maruf International Hospital. It was pinpoint. And I thought this is just tiny ulcer, maybe just. And I didn't take a picture. I'm regretting. But he came back after a week and it was still there, pinpoint. I take a biopsy, it came as a squamous cell carcinoma. So that was the learning point, though I always try to take a picture. So please, whenever you see such lesion, now everyone has a camera, take a picture. The rest is the gold standard. You will do biopsy to prove with the histopathology. Then OPG, chest X-ray, CT, MRI, PET scan. The gold standard PET scan is not available. I will talk a little bit about PET scan. It's not available everywhere, but CT scan is available everywhere. So usually we recommend CT head and neck plus chest, because the most common site, though distant metastasis is rare in oral cancer, but the most common place is lungs. A pen endoscopy, sometimes we see the whole oropharynx. Sometimes you will see with the chest, the direct laryngoscopy. Sometimes we see the tummy as well. But generally, which we can see the oral cancer, we don't need to go to pen endoscopy. Now, what you want to achieve? Patient came to you, you have done everything, patient is ready. Now you have to decide what you want to achieve. So what should be your goal? Your goal? The most important thing is what? Cure the cancer. Eradication of the tumor. If you remember 2 weeks ago, this question was raised by Dr. Zubair that we should not use the word eradication, the cure. Yes, we should use it. The principle of treating oral cancer is to eradicate the disease. This is our goal. Okay? And the other thing is you try to preserve that not only you do the surgery, but at the same time, you have to preserve the body structure as well to restore the form and function, and try to minimize the damage, collateral damage you do to the patient. And one of the other things is, remember, to prevent second primary cancer, remember 10 to 30% these patients will develop a second primary tumor. So what you should do, you need to convince them to stop smoking, stop alcohol, and improve the diet, and so on. Okay. Now, some of the factors before you jump into the treatment, you need to think about that how you will decide. So there is a tumor factors, there is a patient factor, and there is resource factors. We're not going to go into the detail, but patient has to be fit and well enough for the surgery, and the tumor should be resectable. And the other thing is resource factor is basically related to the surgeon, to your resources, to your hospital, ICU care, and blah, blah, blah. If you don't have all those facilities, please refer the patient to the appropriate center where all the facilities are available. Now, we never make a decision individually. For cancer, there is always a teamwork. Always a teamwork. We bring the patient to the discussion with the team, where there is a medical oncologist, surgical oncologist, radiation oncologist, a radiologist, pathologist, the surgeons. We all sit together, and then we discuss in detail, and then we make a decision. There's a big advantage of doing MDT. I know everyone believes that we are the best, but believe me not, the best is a team, not an individual. So always discuss the patient in MDT, where there is a shared responsibility. You made the decision in MDT, you are safe, you are relaxed, because the responsibility lies with the whole team, not only with one person. Unfortunately, majority of the hospitals have no MDT. People are operating individually and then refer the patient afterwards to the radiation oncology for post-op radiation. This is here what I see every day. But you should have MDT. So the MDT team will decide the surgery about the radiotherapy, chemotherapy, targeted therapy, immunotherapy, and combination of these things. The gold standard is the main treatment modality is the surgical treatment. Radiation therapy is purely not working. And in clinical trial, randomized clinical trial, 42 and above lesion, the radiotherapy has been abandoned, that they will not give because the results were extremely poor for pure radiotherapy. So the best modality of treatment is radiotherapy, and then followed by radiotherapy or chemotherapy, depending upon the histology after the operation. Now, the targeted therapy and immunotherapy are very new, and it's not yet implied in the, yes, they are in the clinical trial stages. Now, usually single modality, stage 1, stage 2 disease. I'm sure you will know what is stage 1, stage 2 disease. Stage 1, stage 2 disease is basically T1, T2. T1, the tumor is less than 2 centimeter, and T2 is the tumor is more than 2 centimeter, but less than 4 centimeter. And T3 stage is there is no N1 or M1 in stage 1 and stage 2. So usually you can do both, but this is the old concept. Now I was just reading last night that radiotherapy is not recommended for purely as a primary modality. So primary modality will stay with the surgery. Stage 3 and stage 4 disease will always be multimodal therapy. It has to be surgery followed by radiotherapy plus minus chemotherapy. Now, the question arises how one of the problem with the oral cancer is, or with any cancer is, that it will spread. As for local spread, regional spread, and distance metastasis. So local extension, lymphatic. Why? Remember, head and neck area is a highly vascular area with a rich lymphatic system, which facilitate early metastasis in the lymph nodes. Now, lymph nodes, I'm sure you heard about sentinel node biopsy, but specific, the lymph nodes in the neck oral cavity will drain to mainly to 3 areas, level 1, 2, and 3, except tongue and floor of the mouth. There is a small chances of skip metastasis, but always there will be level 1 or level 2 nodes before it goes to level 4. It doesn't happen that there is no node in the wall and directly level 4 node is involved. And level 5 nodes, I have not done in the last 10 years. So it's level 5 nodes is, I don't know, the old city people might know, the level 5, we are not doing any more. Now, why lymph node is so important? It's extremely important because if there is a one positive lymph node, the prognosis dropped by 50%. How much? 50%. And the second most important prognostic factor is if that tumor comes out of the lymph node, it's called extranodal extension. So these are two most important. The prognosis drops further. So what is it? It's the speedometer, not engine of oncological vehicle. It shows you how speed the cancer is going on. Now, once there is a node in the neck or in the oral cavity, it's a cancer. Now, I always do neck dissection, even with T1. If how small the tumor is, we do neck dissection. Why we do? The neck dissection is therapeutic, diagnostic, prognostic, and staging. Because after that neck dissection, we will be able to decide, because we have to do MT again, and then we will decide whether that patient needs the radiation or chemoradiation. Now, I'll show you a couple of cases that how we approach to the oral cancer and how we operate them. You can see transoral means just we are not going to give any cut from the outside, just go inside the oral cavity and we operate. The upper cheek, we open the upper cheek and you can see the tumor and remove it. Lower cheek, the same is the lower side. And sometimes if we have to reach behind, we have to split the mandible, open it like a book, and we have to reach to the tumor. And why is the approach? We just give cut in the neck, and like a prawn, we take the flap, take it up, and bring the mandible down. You will see it in a minute. Now, it will depend upon the tumor size, site, location, need for neck dissection, or need for reconstructive surgery. Now, this is a simple case. This was a patient was referred to me, where someone has done biopsy and it came with squamous cell carcinoma. When I feel it, there was a hard lump, and I have just mainly it was on the left-hand side. I excise it and I close it primarily, and you can see the now you can see the lip of the operation. Remember, 1/3, when you remove 1/3 of the lip, nothing will happen to your lip. Allah has given us so much flexibility. So that's the main you can see. And this is the after the operation. Perfectly, no issues at all. Now remember why I did like this. This is the tumor, and we have to mark it at least the target is a centimeter. The target is what? A centimeter. But we will talk about the margins, and that 5 millimeter margin is a gold standard, because the 1 centimeter you're trying, the tumor is always more than what you think. and the tumor will shrink. The moment you cut the tissue, remove it from the body, it will shrink. And if it shrinks further, if you put in a fixative, the pathology people knows. So that due to that shrinkage, that's 1 centimeter will become almost 5 millimeter or so. So we will talk about the margin in a minute. So in the UK, the gold standard is that the margin should be more than 5 millimeter. What? But now recent literature says that up to 3 millimeter margin is acceptable. This is something good news for me as a surgeon, that sometimes we always tried to be a centimeter, but we ended up in 3-4 millimeter. Ideally, it has to be more than 5 millimeter, but as I said, the latest research literature say that up to 3 millimeter margin is acceptable. Below that, it's considered as a closed margin. Now, this is another transoral approach. This was a tongue cancer, if you can see. This patient was my first patient in Pakistan. Actually, she became my sister. Alhamdulillah, it's 10th year. She's still alive. She's coming to my home at least once or twice in 3 months' time. Always will come and stay at my home. She has a tongue cancer. That's how I market the tumor. With a try my best to be more than a centimeter. And then you can see this was a tumor, and this is the more than a centimeter margin. Plus neck dissection. Now this neck dissection was the gold standard old. I give a big incision. Now we give only transcervical incision at least 4 centimeter. It's no more there. This was 10 years ago. And she's perfectly okay, alhamdulillah. Now, this guy is 23-year-old Kamran. This was the second patient that came to me in 2014. He's just 23, no smoking, no drinking. He has the cancer. And I did partial maxillectomy without neck dissection. By the way, at that time, 10 years ago, there was no need for neck dissection in the maxilla. Now it is strongly recommended that with any tumor in the maxilla, you should do neck dissection. Alhamdulillah, he's still alive. And I just reconstruct with a simple denture. And you can see the beautiful smile he has. When you see such patient after, and they smile in front of you, believe me not, this is the big reward you get it. The satisfaction is here in your heart. Now, this is the lady from our area. She was operated before by someone else. इसकी चलेगी थी बिजली जी अच्छा sorry there's a electricity breakdown we are sorry for the inconvenience this was the case as I discussed that she has a recurrent tumor and I had to operate. So I removed, did the maxillectomy, including the lateral wall of the nose and exenteration of the eye and reconstruction with the anterior lateral thigh flap. Now, I never cried in my life due to depression. And this is the guy who came from Australia. And every time I met him, he used to make me cry. He loved me so much. He was just 26-year-old teacher. He came from Australia and came to me to Prof International Hospital, and I tried to convince him that look, son, do the surgery. Please, people will derail you for chemotherapy, radiotherapy, and that exactly what happened. So he disappeared, and after 3 months came back to me after chemotherapy, and I said, I explained to you, why did you disappear? He said, no, someone told me that will be better. Anyway, he came back to me with a big tumor, and this tumor I never heard. It's called nut carcinoma. Nut, nuclear protein testis. I never heard that this patient has more information than myself. So I had to do literature review. I did the surgery for him, including neck dissection. You can see that I removed the whole maxilla, the cheek, the eye, the lateral wall of the nose, the septum, and major portion of the intratemporal fossa. Is a huge resection, and including the neck dissection. And you can see, and then we reconstructed with the anterior lateral thigh flap. Unfortunately, non-carcinoma literature, very few cases are reported, and the survival rate is maximum up to 1 year. Maximum up to 1 year, and within a few months, he has recurrence everywhere. And unfortunately, he died on the 27th of Ramadan. I mean, this guy, whenever I saw him at the last minute, I hold his hand. He kept my hand there. I was standing with him for almost an hour. The father used to tell me, please, doctor, you can go. I said, no, until he leaves my hand, I will stand with him. And unfortunately, the father and the family was such a great people that they are still in touch with me, and they are grateful for what we have done. And he was remembered as the most noble person in the family. You can imagine that he died on the 7th of Ramadan. Allah may bless you soul with paradise. Now, this is a general surgeon. He was a general surgeon in army, and he was treated for osteomyelitis. Now, I'm insisting that please don't ignore osteomyelitis. He was treated for osteomyelitis of the anterior mandible in CMH here for a few months. Then he ended up with me, and I say, I'm worried. I did the biopsy, and it came as a squamous cell carcinoma. And this approach is called wider approach. So I give incision from below and remove the whole flap up, bring the mandible down, and resect the mandible from angle to angle. And then we reconstruct with the free fibula flap. Unfortunately, I heard that he has died now. It's almost 2-3 years he has died. This patient is from Multan, and she has a tumor of the retromolar trigon, and which we operated, opened the neck, the mandible. So you can see we have done the neck dissection. Please. And that's how we measure that how much bone I have removed, because we have to reconstruct the same bone. Every year, because she's from Multan, I didn't know that she has garden of mangoes, and I was getting mangoes every year. For the last 2 years, I'm not getting any more, so I'm worried. So I cannot go into detail because people get bored. I have to finish in the next 5 minutes. And this is, and you can see her after the operation. She did very well. But I said that for the last 2 years, I'm not in contact with her. So she has passed away. This is the last patient. She's from Abbottabad. We just did. She has a squamous cell carcinoma of the right mandible. So did the neck dissection with resection of the mandible and reconstruction with the free fibula flap. Now, this lady, when I look at the smile, I love it. And she used to tell me, the doctor, I pray for you in Tahajjud. That's why I'm telling you. That yes, I didn't do for free. These are all private cases. This is not a single case is government hospital. These are all private cases. They pay to me. But what I'm telling you, if you do a good job, they will pray for you. They will give you a gift. So what else we want? So be honest with the patient. So when I see her smile, I'm so happy. And now I'm going to finish it. But this is the last 2 slides. That this is all stage 4 diseases, stage 3, stage 4 diseases. So what is missing in our country? Primary prevention. There's no concept of primary prevention in our country. So what is primary prevention? That we should try to reduce the number of cases in the first place. And what that way you need? You need health education. Health education, not many people know what is health education. In foreign countries, they teach the health education from primary. That what is health? Now, the other thing is that we should discourage the tobacco, which is the main risk factor. And as a dentist, we should encourage good oral hygiene. The secondary prevention is, that's what I'm even more worried, that we should try to detect the cancer in the early stages. Now, oral cancer, the mouth cancer, 90-95% is detected by the dentist. We are grateful to them. But unfortunately, our medical colleagues, they see the patient for sore throat, tonsils. They will jump into the throat, but they will not look at the mouth. So my humble request will be to the medical colleagues to please, whenever a patient comes to you, please examine the oral cavity as well, not just the throat. Where we ended up, what we are doing is the tertiary stage. What I have shown you, this is the tertiary stage. Patient came to us in the late stage and we treat them. Now, summary, we're going to finish it. So the main problem of oral cancer is early detection. Detailed oral examination must always be part of routine medical and dental examination. Surgery is still the most important modality till today. Preventive measures should take priority in management and control of oral cancer, especially in our own country, because we cannot afford, the patient cannot afford, neither we have resources, neither the patient can afford because one patient, if you operate, is almost these days cost you 1 million, plus followed by another $500,000 for radiotherapy, from where they should bring the money. So the best thing is what? Prevention. So I'm going to finish the quotation with this quotation. The word is not dangerous because of those who do harm, but because of those who look at it without doing nothing. So the responsibility lies on us. Yes, pan, gutka, tobacco, alcohol, these people will damage your health. But what we are doing, at least we can contribute. How can we contribute? At least early detection. Our colleagues, both medical and dental, my request is there to please examine the oral cavity. It takes at least 1 to 2 minutes. So your 1 to 2 minutes will save someone's life. Thank you very much. Any question?
The fate of the cells after you have operated.
जोर से बोले.
सर वही पूछना था कि फेट ऑफ द सेल्स क्या होती है? ऑलरेडी लिम्फ नोड्स इन्वॉल्व हो चुके हैं, लिम्फेटिक सिस्टम में आ चुके हैं, लिम्फ अल्टीमेटली ड्रेन करते हैं आपके वेना कवा के थ्रू आपके ब्लड स्ट्रीम में। तो आपने प्राइमरी लीजन रिमूव कर दिया, तो उसके बाद क्या उनका फेट क्या होता है सेल्स का?
Dr. Zubair has asked a very important question that if you remove the primary tumor, so what will happen to the cell? They have gone into the lymphatic system. As I said earlier, that head and neck area is a highly vascular area with a rich lymphatic system that facilitate early metastasis in the lymphatic system. Now remember, Dr. Zubair, that the oral cancer mainly spread. One is through local excision, local area. The second is mainly by lymphatics. The blood mets, if it goes to lungs or liver, this is a very late stage and very rare. The main mets is regional, which goes into the lymphatic. Now, do you know what is lymphatic? Lymphatic system is what? Basically, it's a police force which catch the chore, dark of your infection. The same, they catch the cancer cell. That's why the lymphatic system, when the cell goes into the lymph node, the lymph node will catch it. They don't let the cancer to go out. They will fight within that lymph node. And that's why that whenever there is an oral cancer in the mouth, we will always, now is a highly recommended that you should do neck dissection. And I say why we need to do the neck dissection? To remove any tumor, any cell in the lymphatic system. That is the channel. The channel is level 1, 2, 3, 4, 5. The oral cancer drain into the first 3 lymphatic system, 1, 2, 3, level 1 to 3. Yes, sometimes to level 4. Okay, and that's why whenever we do oral, do the local excision, we do neck dissection at the same time to remove any tumor in the lymphatic system, to remove the cause there. Okay, anyone else? Dr. Saida.
Nowadays, there are different oral scanners are available to detect these cancers.
There are different
scanners available.
Right, okay.
What do you think, how effective they are, or whether only a general examination is enough, or we should go for using them?
Dr. Saida has asked a question that these days different scanners are available to detect the oral cancer. Yes, they are available, but those scanners, what they do, they give you the high risk area. What they give, you still have to do biopsy. Now remember, 2 weeks ago, I have brought a person to show you, and they will come here to show you the new scanner that cost you 25 lakhs. So that scanner show you the green light, red light, and they will show that this area is risk, you should do the biopsy. So my sincere message is that nothing is more better than a proper examination. This is just like a ultrasound. There's no disadvantage. You are not going to lose anything. It just takes only 1 to 2 minutes to examine your oral kidney. Yes, the other thing, what we forget, please don't forget yourself. How many of you have checked your own mouth? Yes, one. Have you checked your mouth recently?
Yes, sir.
Yes, I'm thinking, because we don't examine. I tell my wife, my sister, my mother, I don't tell you shame. I tell you to examine yourself, your breast. The problem here is we feel shame in it. We don't feel shame in anything. But when it comes to the medical term, then we feel very shame. I said that I tell my sister, my wife, to examine yourself, especially your breast. So why you can't examine your mouth? So the humble request is to please, once in a week, once in a month, check your own oral cavity. You don't need to go to the doctor. And I say, I already prepare the doctors, the medical specialists. then you check the person all the time, check their throat. Believe me not, they will jump into the throat, but they will never look into the oral cavity. It takes only 1 extra minute, but you can save someone's life. Early detection, through early detection, you can save many lives. And if you save one life, you save the whole humanity. Zoeb, any question from your side? Okay. इसको आवाज आती है?
हाँ जी.
चलो आप.
Okay, thank you very much for such a nice presentation, especially considering the high prevalence of oropharyngeal squamous cell carcinoma in the northwestern and especially in the Afghanistan region as well. And that's why even I have seen in the last 2 years in RMI, there has been a boom in the medical tourism in Pakistan because of this one reason as well. I would just like to comment on the radiological management of the oropharyngeal cancers. Like we know that the gold standard is MRI and CT and all that, but because of the recent advancements in the CBCT technology, the studies have shown very good effectiveness of the CBCT imaging modalities in the diagnosis as well. But in the last 2 to 3 years, there are studies which are reporting the effectiveness of the CBCT as an early predictor of a treatment response in oropharyngeal squamous cell carcinoma. But there are no guidelines yet. And there's evidence, but the evidence is weak. So what are your opinion on that? Because the main problem over here is that, as you said, the early detection of this cancer. And because the CBCT is now more readily available in comparison to the CT and MRI.
If I rephrase Hana's question, the role of CBCT in the early detection of oral cancer. First of all, the oral cancer means the cancer of the lining of the oral cavity. This is the first clarification. What the CBCT will help us is where there is a tumor in the bone. That will help us in early detection. But so far, the best evidence, one of the best specificity is OPG followed by CT scan, not sensitivity. Sensitivity for CT scan is 87 and 77. This is two different, but specificity is almost 100%. The problem here is that CBCT for oral cancer in the soft tissue, for better marcation, you need contrast. You have to have contrast. For bone invasion, yes, I agree with you. The CBCT will help us in the early, but for the soft tissue, local area and neck, we need contrast enhanced CT scan. I don't know that in the near future, the CBCT will have this utility. I don't know the answer. MRI, the problem with the MRI is very good for soft tissue, but not that good for the bone. The problem is when there is inflammation, edema, the MRI overestimate the invasion. So the early, usually the early cancer will not cause erosion. The erosion, invasion of the bone takes time. That will be my answer.
Yes. Okay, and what about the early predictor, using CBCT as an early predictor of a treatment response in comparison to medical CT? Because after treatment or after surgery or chemotherapy, radiotherapy, we often go for the medical CT and exposing patient to more radiation. So why not we should go for the CBCT? And especially, especially it's offering more spatial resolution, better than the medical CT. So we should go for the CBCT post-treatment prognosis.
I think what you mean, that the role of CBCT in the surveillance area to detect the recurrence of the tumor rather than doing the CT or MRI, the gold standard is PET scan. The gold standard is PET scan. The reason is that due to the surgical changes, the anatomy of the area is changed due to surgical changes, followed by the post-radiotherapy changes. So the early detection both on the CT, MRI is very difficult and questionable. And that's why they went into the PET scan. The PET scan, what is PET scan? Positron emission tomography. What they do physiological. What they do, they show the metabolic area. When there is a high metabolic activity in that area, it's basically glucose, and there's a high uptake of glucose by that metabolic activity compared to the rest of the normal tissue. That area is considered that there is a tumor recurrence, and that's why the CT, even the CT MRI role is weak. Now people has gone to PET scan for the recurrence, for the surveillance. Anyone else?
So, sometimes the patient came with a very chronic history of dental infection, और जिसमें सर नॉर्मली गम टिश्यूज भी काफी इन्फ्लेम्ड और समटाइम महीनों उनके इश्यूज चल रहे होते हैं, तो ऐसे केसेस में सर हमें बायोप्सी वगैरह लेनी चाहिए या नहीं सर?
I should have not missed this question. Well done, Kamran. The gold standard is that if there is a ulcer, lesion, white lesion, red lesion, thickening of the mucosa for more than 2 weeks after removing the apparent factors is still there for 2 weeks, you should do biopsy. You should do. You are not going to lose anything. So please never hesitate to do biopsy if you think the lesion is there for 2-3 weeks. After removing the sharp denture, the sharp tooth, you should wait for 1-2 weeks. If still there, then don't hesitate to do biopsy. You are not going to lose anything.
So, but if there is a problem and initially we do the extraction and then, sir, क्या वो speed up नहीं हो जाएगा sir अगर वहाँ पे कोई carcinoma है?
Ajahn, please, well done, Kamran. Please, it's happened very commonly here that there is a lesion there and people take the tooth out. You have destroyed the patient. Now the tumor is gone into the socket. It's become very easy for you. So please, if there is a lesion around the tooth and you believe that you are concerned, so please don't remove the tooth. Take opinion. By reaching the patient, you are helping the patient. By removing the tooth, you are damaging the patient. So please, because a patient came to me, people have taken the tooth from the tumor. So please never remove a tooth when there is a lesion around the tooth and you believe that there is something nasty. You are worried. I'm not talking about simple periodontal problems. You are all dentists and you have seen the oral cancer. Take a second opinion. Now, especially here, we are such in an environment that you have easy access to all of us because you are giving more chances for the tumor to spread quickly. Or remember, tumor is like a dog. The more you hit it, the more it will respond. Okay? So, gentle. But yes, biopsy is compulsory. And sometimes, if I believe that this is because we have so much experience clinically that this is a tumor, I always give it after photograph, I send it for the CT. I know people said that without histological approval, you should not go for the CT scan, but you can measure it. Because if you do biopsy, then try your best to do the CT scan straight away. I personally do the same time. I don't wait because clinically, if I believe this is a tumor, it's a tumor. 99.9% I'm sure it's a tumor. Because that will give you a wrong information about the size of the tumor, the depth of invasion. There's one more thing is coming very fast. It's called depth of invasion. I know the majority are not surgeons, not the cancer people, but depth of invasion is another problem is coming, and that will give you a wrong information if you do biopsy in a wrong way or deep. So, but yes, biopsy should be done, but not the tooth should not be taken out. Anyone else?
Sir, can we perform, for instance, if the tooth is symptomatic, can we perform root canal therapy to just leave the vision of the vein?
No. If you believe that there is a lesion there and you are concerned about the tumor, that no, it's not recommended to do. Because that tooth will be almost loose. Okay, one of the sign symptoms of the cancer is loosening of the teeth. Yes, if you don't know, if you cannot see the tumor on the outside, then you can do whatever you want. But if there's something around it, then you should not do it.
I think she wants to say if patient is in severe pain, then
you can medicate her because by opening the area, I'm not sure that
just open the tooth and place some medicament.
keep in mind because that area you give infiltration. You're not spreading the tumor. Okay.
How into the block?
Yes. Yes, if the tumor is here, you give a black aspirin, but if the tumor is in the retromolar tragon, I would never encourage to do no. And retromolar tragon tumor is the worst. They spread very quickly. Even a small tumor can spread very quickly in the malaria.
We need to understand the ignorance of our society. They get relieved of pain, they're not going to report to any dentist ever.
That's the problem.
To keep them in pain so that they report and get a bigger problem. That's how our society works, actually.
You are 100% right.
You're saving them from a bigger problem.
The problem,
give them pain.
the problem is one other big. Then we have to finish on. One of the big problem is that people don't refer a patient. The doctors here in private sector, they kept the patient with themselves. Believe me not, when the patient come to me, at least 4 or 5 doctors, surgeons have seen the patient. Patient will go from one minute to another. So fear Allah. If you believe that this is not your job, refer to that person. But here, that's what I'm seeing. When the patient comes to me, already he has seen, even including Shifa, when the patient will go 1, 2, 3, 4, 5, medical specialists who are treating the couple of cases with Mungina. And that stage 1 tumor after 4 months become stage 4. Who is responsible? Who is responsible? That medical specialist. And I told him in a nice way that please don't treat cancer with the Mungina. If you believe the patient, refer to ENTs, refer to Maxillofacial, refer to plastic, someone with experience. But here, we kept the patient ourselves. That's the big dilemma in Pakistan. There was a hemophilia patient with me, and I said one of the best hemophilia doctor is Shaukat Khanam. He was with us in Dublin. He said, no, some neurosurgeon is looking after me. Neurosurgeon was looking after his hemophilia. That's why we cried. I saw it with my own eyes. Urologist was removing lump from the neck. I witnessed myself in a small private hospital. Sometimes the heart cries that we have no morals, no ethics. Remember, one day you will be the patient. Your mom will be a patient. Your father will be a patient. Your son will be a patient. That's what we forget. And on that day, you realize that how should I speak to the patient, to their family, and how they should be treating me. And then you will realize the nurse is important or not. Chowkidar and the door and the main gate is important or not. We don't appreciate other people. We think bas. आप लोग बोर हो रहे हैं नहीं दिल दुखता है Thank you very much. Okay, thank you. Thank you.